Good evening, everyone, and welcome to the EUROGEN webinar series. My name is Michelle Batty, and I'm the manager of the ERN that we call EUROGEN. And EUROGEN deals with rare urorectogenital diseases and complex conditions. And they're generally diseases or conditions that require highly specialised surgery. So really where the expertise is rare. And EUROGEN is one of 24 European reference networks that were created by the European Commission in 2017, and they've been kindly funded by them currently under the EU for Health programme. And EUROGEN is currently a network of 56 healthcare providers in 20 member states. So what is EUROGEN aiming to do? Well, we aim to deliver quicker specialist evaluation and more equitable access to high quality care, diagnosis and treatment for patients with rare urorectogenital diseases and complex conditions. And some of our activities, well, I hope you saw at the beginning of the webinar, one thing we do is we conduct virtual cross-border case consultations using a highly secure platform called the Clinical Patient Management System, which is a tool given to all the 24 ERNs by the European Commission. So this is a completely free service to any healthcare professional working in the European Union. So please don't hesitate to get in touch with us via our website. We'd be really delighted to help you with some case discussions. We also produce clinical guidelines and clinical decision support tools together, and training activities like this webinar programme. And a very exciting development is we also have a patient registry. We know this is very important to collect data so that we have the evidence for our clinical guidelines, and we also know the registry is really helpful for research purposes. So without further ado, the title of our webinar this evening is the validity of robotic donor nephrectomy in a smaller, limited resource European country. And I'm delighted that we've got here with us this evening Albertas Cekauskas, with apologies for my Lithuanian there, and he is head of the Urology Clinic at Vilnius University Hospital, Santaros, Klinikos, and they're a full member of the network, and we very appreciate Albertas being here with us this evening and sharing his perspective from his country. So thank you so much, Albertas.
Hello. Well, thank you very much, Michelle, for a nice introduction, and I'm thanking for also invitation to the EUROGEN webinar session. So, unfortunately, my colleague Augustinas Matulevičius is not present here, but he did some work on the slides and did a nice help for making this presentation. So I'm trying to now to share the slides, and yeah. So today we talk about living donor nephrectomy, which is an important part of the transplant process in general. So I have no conflict of interest regarding this presentation, except that I'm a robotic surgeon and I work with the Vilnius robotic system. So that might be my conflict. So Lithuania, well, small country, probably not very big, and if we would look to the big countries, so it's really small. So we are 2.8 million. However, the biggest in Baltic region, so with together with Estonia and Latvia. And well, just to put in the context how financially we are standing at the moment, so about 60 billion GDP at the data of 2023, I suppose, and how much we provide provide for the health. So it's about 7%. So we are not in the highest league for supporting the medicine. It's quite average. We stand to our neighbor Poland and some other countries, as you can see, maybe spending maybe twice as much. So most of the expenditures for the public health is spent by the public sector, and so one per capita it's about 2,500 euros. We're happy to see that our GDP was growing since we became independent, and in 2019, and after the crisis, economic crisis, our GDP is constantly rising. So we are hoping that it will help also to make our medical care even better. So now going back to the subject, we are here's the presented data what we have regarding the disease donor kidney transplantation. So this is the official data from our National Transplant Bureau. So we do approximately up to 100 cases per year. So this data is up to the mid last year, which is presented officially on the website. We are two centers which are providing this service. So Vilnius University Hospital, Santaros, Klinikos, and the Kaunas, our colleagues from another city. We do about a half, or maybe a little bit more than a half of these cases. About living donors, so the numbers are going up and down. Recently, we didn't do very many transplants. The last year, about 6 transplants. The biggest number was in 2014. 13 living donor transplants. It a little bit depends on the number of patients in the waiting list, and also from activities from different centers. But most of these cases are performed in our clinic. Pancreatic and kidney complex transplants are quite incidental. They are performed when there are specific recipients. So recipient list is not very high for this part. So at the moment we have around 130 recipients waiting for the kidney donation, as well as 2 cases of kidney and pancreas. So not all donors are actually matching for these recipients. So these cases are quite scarce. If we talk about our donation system, we have about 50,000 people who have taken the donor card, and they're willing to donate if something happens. And at this point, most of them are willing to donate all the organs which signed this informed consent beforehand, and they are having the issued specifically issued cards. So if talking about technology, we went quite a long way. So so from laparoscopy, from the monitors which were big and small at the same time, then to LCD monitors, and finally we developed a 3D laparoscopic program. And now I'm actually happy to tell that in our center, probably all of the, if we talk about oncology, so we perform all the partial nephrectomies, almost 95% laparoscopically, and also radical prostatectomies are performed either laparoscopically or robotically. And in 2023, we also were lucky to have probably the first ones in the region, the robotic system, which is British system, Cambridge Medical robotic surgical system, which is called Vercius. So living donor nephrectomy endoscopically, if we look at the European guidelines, so the guidelines recommend to perform living donor nephrectomies in general endoscopically. So it should be done in established, well-established programs where we can actually be more safe. Nevertheless, still mini incision and mini laparotomy or mini incision, flank incision can be also be performed if there is no other possibilities. However, the endoscopic living donor nephrectomy is different. So you can have a pure or hand-assisted transperitoneal approach, which we started, and we did the pure transperitoneal laparoscopic approach. And this is the way we started because we had quite a big experience in the oncology and nephrectomy, partial nephrectomy, and laparoscopic program was well developed. Then hand-assisted and pure retroperitoneal approach, which can be done also. Endoscopic single site less, which is probably not that common and probably needs even more surgical learning curve, and it could be performed in specific centers, and which I was happy to see in Spain, and Professor Alcaraz is very known for the nodes procedures, so natural orifice procedures, which can be also performed through convex of vagina, and removed. The kidney could be removed without making any scars in the abdominal cavity. Laparoscopic, endoscopic single-site surgery, and robotic single-site surgery also is gaining momentum. So robotic single-site with the development of the single-port robotic system of Da Vinci is also now coming back, and less procedures are coming back now with the help of the new robotic systems. So what about results in short? So the if we talk about transplantation guidelines from the EU guidelines section, so open and laparoscopic surgery probably more or less similar if we talk about graft function, rejection rate, urological complications, graft survival rate, and recipient survival rates. Pretty similar depending on the study. However, the laparoscopic approach is much better if we talk about analgesics, use of analgesia, postoperative pain, hospital stay, and time to return to work after the surgery. In general, the procedure, both laparoscopically and robotically, are performed in the similar position, so the plank position. This is the way we started the procedures. So we used 11, 13, and 5 5mm trocars. The 13mm trocar is used for stapling device, the artery and vein stapling device, because the difference from the regular radical nephrectomy, if we perform it for oncology reasons, it's different because we need to have the whole kidney dissected, and then only then, when everything is done, we can dissect the arteries and veins of the donor. So from the publications, and there were a couple of lethal cases using the locking polypropylene clips. So by FDA, it is has a contraindication to be used to clip the main arteries, and the suturing device, the stapling device, should be used. So the story is already from the 1995. The professors Ratner from Johns Hopkins University performed the first laparoscopic nephrectomy, and with a warm ischemia time, which is quite acceptable for that time. So less than 5 minutes. Very nice surgery first time. So we went quite a long way, and we started our laparoscopic procedures in 2017. Actually, we were the first in the region, and since then, all the procedures are performed laparoscopically. So we try to, living donors are usually performed by the same, by the two main surgeons which do the transplantation, and I myself perform the laparoscopic procedure in order to just to remove the problem of risk of experience and so on. So we had a wife donating kidney to the husband. It took about 3.5 hours, and warm ischemia time was 3.5 minutes. So you can see the final result. For the removal of the kidney, we used the suprapubic incision, and so to say, a golden line. So the trocar is placed in one line, and we didn't use the accessory trocar. In this case, just the two working trocars and one camera trocar. And thank you for my team. So of course the transplantation is not only the surgeon, so this is the whole team, the anesthesiologist, the nurses, everybody got ready for that procedure, and of course nephrology team, which actually is taking care of the patient. So this is our data, how many laparoscopic living donor nephrectomies were performed since 2017. So all of the cases, which all of the donors which were prepared in our facility, in our outpatient clinic, all were harvested. The kidneys were harvested laparoscopically, and nephrectomy was made, and kidney was removed through the suprapubic incision, like Pfannenstiel incision. So all the cases, 27 cases, like probably in quite many countries, we have gender discrepancies a little bit. The females are donating more than males. The average age about 50 years, and we also had a grandmother who was donating her kidney to her granddaughter. Mostly the left nephrectomies were performed. In this analysis, there was no just one right kidney nephrectomy. It is a little bit more complicated to do the right kidney nephrectomy. In general, probably not the harvesting of the kidney, not the nephrectomy, but the transplantation can be a little bit more difficult with the shorter vein and shorter arteries, or sometimes the veins can be bigger number, 2 or 3 veins, then it makes the life a little bit more difficult. But recently we performed another 2 right cases in the end of the last year. So duration, more or less, about up to 3 hours. We performed surgeries in 2 separate operating rooms. So the procedure starts in one operating room, and concomitantly the other surgery starts for the recipient. And the kidney is taken from one surgery room to another, and warm ischemia time usually, cold ischemia time usually doesn't take more than 1 hour, about average 40 minutes, and warm ischemia time was about 6 minutes on average. So going more close to the subject of the robotic-assisted living donor nephrectomy, well, we have similar advantages if we use a robotic system in this case. So we have the same smaller incisions compared to the open surgery, and the advantages are shorter hospital stay. The patients return quicker to their activities, and there is a higher satisfaction rate with the procedure. And of course, we have with the robotic system, we have better visualization. So of course, if we use the 3D vision with the laparoscopic technique, we have also the 3D vision, but maneuverability of the instruments gives us much better positioning of the instruments. And also, as I mentioned, that we have to prepare the kidney, including the upper pole, lower pole, and ureter before sectioning the vessels. So it really helps to mobilize the kidney and not to crush the different tissues. And that's important, because with the laparoscopy we are straight, and it is, I usually now compare it with the Chinese chopsticks, and now we use the rotation instrument. Of course, it needs a little bit more budget allocation. In our case, we do not have special budget for the robotic system, an extra budget. So we get reimbursed the same as we would perform it openly, laparoscopically, or robotically. And more or less with our system, we have an extra 1,700 euros for each surgery, an extra amount we have to spend for the instruments and for the draping of the robotic system. So the technology is not available everywhere. So we were lucky to be the first ones to receive this type of system in our department, and then in Baltic region as well. But I think this is quite now getting the momentum, and I think these systems will be more widely accessible in our region. Surgeons also has to be trained. So we have four trained surgeons which underwent special training, 5-day training with the dry lab, wet lab, and also the cadaveric training for different procedures. And after probably 4 months of active work with the oncology patients as well, we finally took the case of living donor nephrectomy. So you can see this is the system which we are using, the Versus system. It is different. Probably the most common system is Da Vinci system, is where all the hands, so to say, are connected to one tower, and this is the multi-model model system, which you have different working hands, which are called bedside units, which can be positioned in different places around the surgical table. And as well, we have it's an open system, so we have the vision, the monitor in some distance, which is quite close to the surgeon. It's possible to do surgery standing and sitting. Mostly, I prefer sitting position as to also other robotic systems. But for some surgeons, if they feel better, they can use also the standing position. As well, we have to evaluate the patient, of course, as in open surgery. This is very important to have a knowledge about the arteries, veins, number of veins, where they separate, and so on. Special evaluation of the donor health status. And BMI is important as well. So we take up to not more than 30 BMI, and preferably 25. So talking about the instruments which are used. So actually, you don't need that many instruments. In our case, we used only the Maryland grasper and the scissors. And for the retraction, you can use, if you use four hands for the surgery, you can use also the retractor, fenestrated grasper. But in general, even for this procedure, 2 main devices are needed. And the positioning of the bedside units, the separate working instrument hands, which are holding the working instruments, could be placed around the table. So one way is to put 2 two bedside units on one place and two on the other side. Another way is to use two working hands on the two bedside units on one side with a visual bedside unit and an assistant bedside unit on the other side. The way we used for the surgery, we used three bedside units, so one visual endoscope and two working trokers, so to say. So scissors on the right hand, grasper on the left hand, and we also use the accessory assistant port for the stapling, for the suction device of the assistant. So thank you, Augustinas Matulevičius, for helping me to perform this surgery first time. So what are the possibilities? So this is the setting which we're using. So the video bedside unit is here, endoscopic, and two working hands which have color coding, so to know which instrument is which. And it helps to have an extra space for the assistant in the middle, so he can do the work by the table, and also is helping to put the kidney into the collecting bag and to remove the kidney at the suprapubic incision, which is pre-prepared before the final cut. And it just a couple minutes are needed to remove it and to transfer it to another table to prepare it for the transplantation. So this is the setting. So you can see the two working bedside units and one visual endoscopic bedside unit, and the assistant standing on the side. So a little bit similar setting as we would do for laparoscopic procedures. Another way of performing this procedure is 2+1. So you could do one bedside unit with a grasper on the anterior part of the patient, and from the posterior part you put another right hand port, and it is placed on the side of the back of the patient. So you have enough space here as well for the assistant to work between two bedside units. So the procedure is similar to the laparoscopic procedure. You need to separate, to dissect the whole kidney, to dissect the renal hilum, to have enough of vein, which is usually dissected a little bit medial to adrenal vein, and also to dissect all artery until the aorta. So that's why you shouldn't use the Hem-o-lok clips for artery, because these lethal cases which were presented, published some already time ago, probably were related to the Hem-o-lok clip very close to aorta, and if there was a very short stump, it might have led to a rupture of the renal artery and lethal outcome. So of course we need to talk about financial implications. Of course, if it has a bigger burden on the medical system, so we have a little bit higher cost. So this higher cost is direct cost. However, we have a shorter hospital stay, which is indirectly reducing the cost of the whole procedure, and also the patient satisfaction rate. And as well, I always try to stress that the patient who is giving the kidney and he's donating the kidney, he's on this side, that he's probably the main person. He's the main person in this procedure. He's doing the gift for his closed one, and he should receive the best quality care. If we compare robotic to laparoscopic, so this is one of the European center data comparing the robotic and laparoscopic technique. You can say that the main difference which was seen, so slightly better hospitalization time, so 4 and 5 days. You can see the a little bit longer, 1 minute longer warm ischemia time in robotic part, but on a whole, we can see that it's pretty similar outcomes as we can see for laparoscopic, both for laparoscopic and robotic procedures. However, a slightly, but not significant lower numbers of complication rate, labial rate on the robotic side. As well, another study says that we have a little bit less pain using robotic procedures, both doing the right and left, both 6 hours, 24 hours, and also 48 hours after the procedure. It's difficult to say why it is so. However, maybe the less trauma to surrounding tissue, nicely done dissection, less crushing of the tissues might lead to a little bit better results with one VAS scale less than of the laparoscopy. However, this data should be still rechecked. So, of course, having the robotic system, I think this is one of the just starting steps, and we always we talked about it several years ago about laparoscopy, and especially these countries which received this technology a little bit later got these discussions that whether we have to do it, whether it's important to do it, whether it's worth doing it. However, we see that these procedures now are everyday procedures, and we cannot even realize our surgical day without them. So the same with the robotic system. So we have coming the artificial intelligence technologies, which might give some better insights during the surgery. Also, augmented reality, 3D visualization. So especially oncology surgery. So now we have places which are actually overlapping the real vision with the augmented reality vision and showing the tumor place. In transplantation, it's very nice if we have complex arterial network. If we have 3 veins, 2 arteries, 3 arteries, 2 veins. So in that cases, we might have an advantage. Also, research opportunities are also quite high in these settings. So we have augmented reality, we have virtual reality, we have a way to teach our surgeons. So as well, I would say that the better technologies which are used for the transplant process in general, and as well for the harvesting of the kidney, for nephrectomies of the living donors, which are non-diseased patients. They have no disease. So in this case, we are treating the not a patient but the person. So in general, we have to use the best technologies for them. So one more review, which took 12 selected trials published in Annals of Royal College. Analyzed also these main surgical endpoints. So we see if we talk about hospital stay, it's slightly more to the side of the robotic system. Postoperative pain to robotic system. Postoperative morbidity is more or less equal to both for both types of surgeries. Operating time is a little bit longer in laparoscopic, so in experienced hands, robotic system becomes even a little bit faster. Also, the blood transfusion is pretty similar, slightly to laparoscopic part, but we are talking about 10 milliliters, which probably I would say completely not significant. Warm ischemia time is slightly on the side of laparoscopy, a little bit longer in laparoscopy, and also conversion rates. Conversion rates are less likely if done robotically. So one more very nice review from University of Minnesota. Of course, that the best surgeons, the best technologies. So they reviewed all the living donor cases. So the history, how they went from open to robotic, hand-assisted, laparoscopic, and robot-assisted surgery. So here is the robot-assisted surgery. This is the plain complete laparoscopic, and this is hand-assisted laparoscopic, which in this case, up to this publication date, which was 2015, I believe, at that point they were decided to go back to laparoscopy, and I think they went back to the robotic system afterwards. So pretty similar patients. Patients are of BMI up to 25. They have well, similar groups. And what we can see that OR time is a little bit higher in the robotic group. All other groups are similar. If we talk about the blood loss, of course, the open surgery, the highest blood loss. The other procedures are quite similar. Then you can see that transfusion rate and also intraoperative complications are more prone to happen in open surgery setting. So for this publication, it was published in 2016. So at that point, they decided to keep on doing the hand-assisted laparoscopic approach, which probably gives the best time of retrieval of the kidney, because it's in the hand and you take it. But our center started laparoscopic, and I think that the surgeons are quite advanced in laparoscopic technique, and now it is quite very acceptable to do it completely laparoscopic. So we came into this market later, but we stayed with a laparoscopic only technique. So if we talk about outcomes, recipient graft failures, a little bit higher in the open surgery in the first year. However, it evens up into 10 years period. However, if we see it is a little bit higher and is significant in 5-year term. So this is the first procedure. So on November 23rd of 2023. So this time the husband donated kidney to his wife. So quite a nice coincidence. Now we have a payback, so to say. So the surgery took a bit longer, to up to 4 hours. However, ischemia time was about 4 minutes, and we had to wait a little bit for the recipient to get ready, and the procedure was uneventful. So we're happy to have this procedure introduced in our armamentarium. So if we talk about transplantation guidelines, so what do the guidelines say? Strongly recommends to do the pure or hand-assisted laparoscopic retroperitoneal surgery or laparoscopic or retroperitoneal surgery for living donor nephrectomies. If we choose robotics and other approaches, so this should be done in centers which have a high volume and highly specialized centers only, if we have these systems. So I think if you have a big robotic program and performing oncology surgeries, I think urologists are quite ready for that, to do that also in robotic setting. So the policy implications. So we need to talk about reimbursement to increase awareness about that and try to receive acceptance for better reimbursing the patients. If we're giving recipients donors, we give the better technologies. Also develop some funding possibilities, and talk about the regulation of these procedures. And as a final remarks, I would like to say that precision of this surgery is important, and we need to take in account the patient outcomes, pain, loss of blood, blood loss, hospital stay, return to his everyday life. Because one more time, these people are not patients; they are actually good people giving the kidney to their family loved ones. As well, I think if we give this procedure the best technology to these donors, then we might probably get a better results in recruiting the donors and willingness to donate. And now I always say to the donors who are willing to give the kidney that nobody will even understand what kind of surgery was performed for this person, because the incision is in the lower abdomen, in the bikini line. It's not almost not seen, and if the man has the here on the bellies, so no incisions will be seen after the surgery. So this is important. And also the future is the research possibilities, other technology implementations, the virtual reality, AI, which is coming to every single part of the world, and also the medicine as well. So in technologies, it will come either we want it or not. So thank you very much for your time. Thank you for listening. And if you have any questions, I'll be happy to answer or to discuss. Thank you.
Okay, thank you very much indeed. That's a very interesting presentation. So we'll now invite anybody, if they have a question, if you can start putting them into the Q&A, that would be fantastic. Just while we're waiting, we have got one question in for our project manager. 1 second, just before we do that, just a reminder to everybody that the session's been recorded. I will be sending out the links to all the registrants tomorrow. It'll also be put onto our YouTube channel, so please subscribe there. You'll get an automatic notification once it's up there as well. Just a reminder as well that everybody here today who's attended will receive a survey. You'll get one directly after the webinar. You'll also get an email later, so you can choose to fill it in later if you wish. If you complete that within 2 weeks, you will get sent your EACME accreditation certificate, giving you 1 CME point as well. So while we're waiting, so yeah, Michelle, if you could say the floor, there was a quick question. There was a question for you after your little presentation at the beginning. Hope you can see that. So.
Yes, can you hear me?
Yeah, we can, yeah.
And you can see me?
Yes.
Yes,
okay.
I can't see myself in here. So yes, I think there was a question about funding programs for a patient from Africa born with an anorectal malformation and a rectourethral fistula who underwent multiple surgeries in the USA. So it's probably important to clarify, ERNs don't have any capacity, sadly, to provide funding for treatment for patients from abroad. It's more about the knowledge sharing. So all our activities really are trying to transfer that knowledge between the different healthcare providers and experts working with them on the rare and complex, the really tricky cases. But what I would suggest, I'm not personally aware of any funding programs, but we do know the power of the patient organisations. So I would definitely encourage you to go onto our website, and under our anorectal malformation expertise area, there you can find a list of international patient organisations, and there's a couple, there's one at least working on anorectal malformations. And I would also recommend contacting EURODIS, which is the European Umbrella Patient Organisation. So both emails are on our website. So I'd send them an email and they may be able to help you a bit further. I don't know if we have any clinical questions now, Darren.
One come through. Yeah, thank you for that, Michelle. That's a good answer. Thank you. Yeah, so
No problem.
Albertas, I think you see a question maybe come through from Joseph. You click on your Q&A button, You should see the window come up with questions, hopefully.
Just a second. Yeah. So.
Okay.
Okay. Congratulations in your group. Highest living donor, age 71 year. What's your age limit for donor kidney? In general, we do not have official donor limit. So that was actually the doctor and was actually having just one antihypertensive medication. So no, we don't have specific limit for that. But I think that the most important thing is to evaluate the situation, evaluate the risks and especially risks for the donor and the needs of the recipient. So I hope I answered your question.
Okay, yeah, well, I will see if there's any comeback from that. We'll give it a minute. Thank you. No other questions at the moment. So just a reminder as well, things I forgot to say earlier. So please also to everybody, please check out our website. You'll see in there the list of our forthcoming webinars. The register buttons will be put onto those as soon as we kind of have them all set up. I've just done them all next week as well already. So trying to think if there's anything else I need to say. I can't think of anything. So just give it a few seconds more. If anyone has another question now, please put it in now. I would say as well, if you're watching this back on YouTube, if you want to ask a question, please put that into the comments, and then we will pick that up. Our business manager will collect those, and we will pass them on to the presenters. Okay. Okay, I don't think we've got any more questions. Okay, I will start wrapping up, but we'll see what happens. Maybe something will come through. So again, thank you, Dr. Cekauskas. It's a very interesting presentation. Thank you for taking the time to do this for us. It was much appreciated getting things from the angle in Lithuania. Really interesting indeed. Also, thank you to everybody who attended. As usual, hope we'll see you again in the near future at a future session. So yes, I hope everybody has a good evening, and thank you very much indeed. Have a good evening all.
Thank you very much. Have a good evening. Bye.